My name is Jens Lindberg, and I'm the CEO for Medivir. And what we are doing, and what I will focus on today, is we're developing the first liver-targeted treatment for advanced liver cancer. And to kind of build on what Sten said, there is a massive unmet medical need in the world of liver cancer. This we know, and we're not developing an obesity drug, so why am I sharing this? And that is because this, for many patients, leads to fatty liver disease. So 25% of US adults have fatty liver disease today. And what's the link to liver cancer? And that is because Karolinska relatively recently showed that you have a 17-fold increased risk of liver cancer if you have a fatty liver disease. So massive unmet medical need, and this will just going to get bigger as we move forward. The key element with liver cancer, different from other tumor types, is that it's the primary tumor that kills you. In many other tumor types like lung cancer, it's the brain metastases or metastases in other parts. In liver cancer, it's the primary tumor. So that's the one you want to treat. What we're doing at Medivir is we're doing something that no one else is doing. So we've developed a liver-targeted agent. So just kind of summarize this. If you go top left, so what we've done a very clever way of getting a very potent cytotoxic agent into the liver. If you give a cytotoxic agent intravenously, good efficacy, a lot of side effects. We've paired it with the prodrug. So what that does is that when you swallow it, it's inactive. It's stable in blood, stable in the gut, but it's inactive until it reaches the liver via first-pass metabolism, and it's rapidly activated, trapped inside cells. So we get it to the liver. And the second part, which you see sort of on the stains up here, sort of the brown stain, shows that liver cells, healthy liver cells, rarely divide. And for cytotoxic to kill cells, they need to divide, proliferate. Healthy cells rarely divide, tumor cells do. So what we see is that we induce DNA damage in tumor cells only, sparing healthy cells. So what we've seen and are seeing, and to the right, top right, is that the data we're generating in the ongoing study showing substantially improved efficacy. We're more than doubling the time to progression for these patients, what they would be expecting from treatment today. So what we have as an opportunity, if you go to the bottom left, there is an opportunity to move with speed to market, and there's an opportunity to actually be the first approved treatment for these patients. And this market alone, bottom right, that's the second line advanced liver cancer space, is valued in excess of $2.5 billion. So an opportunity to become the first treatment for these patients. We have sort of good momentum in the program. We presented sort of the mature data at ESMO a couple of weeks ago, sort of showing sort of improved efficacy. We just recently signed a collaboration with Eisai from Japan for the upcoming registrational study. And we had our monotherapy proof of concept sort of published in Q3. So the program moves ahead with nice speed. The current phase 1b, phase 2a study is winding down. We still have a few patients on drug, but we are closing it down, and we've run it across 3 countries, including Korea, and that is extra important because a large part of the liver cancer patients in the world are in Asia. So as I mentioned, what we're seeing is quite strong efficacy. On the left-hand side, the same graph, Kaplan-Meier graph showing 10.9 months until progression, and that's just a number until you start comparing it what you would be expecting or what you're seeing in other studies. And that's what you see on the right-hand side. So across multiple studies with other current available treatments, that time to progression is around 3.5, 4 months. So the 10.9 compares very favorably what you would expect in today's treatment. And that's for time to progression. Data with a lot of numbers, but basically what this one is saying, regardless of whether you look at time to progression, whether you look at overall response rate, disease control rate, we do compare very favorably with sort of the current available treatments. The other part that is important, if you treat a liver cancer patient with a potent cytotoxic, If you direct that cytotoxic into the liver, you want to make sure that you save your healthy liver cells, as I talked about in the beginning. And what we can see, and we've measured over time, so these are the first 6 months of treatment, and we follow this longer as well, we basically see no impact on liver enzymes or normal liver function. So again, we are able to get the drug into the liver, we kill tumor cells, and we spare healthy liver cells. This is why we're moving now. We're transitioning from that phase 2A into a registrational phase 2B. Again, this is an area where there are no approved treatment options today. So we are looking to initiate phase 2B in the first half of 2025. The ability to run this study relatively quickly is high because of the high unmet need. So we're looking to have a study readout in the first half of 2027 in order then to initiate processes like breakthrough therapy designation and accelerated approval processes. As I mentioned, we just recently, we talked about sort of collaborations, etc. We've been sort of speaking with Eisai for quite some time, and Eisai is the producer of Lenvima, which we are combining with. So we're very happy that sort of they signed a collaboration with us, and that collaboration includes they will be supplying the drug to us, which for us otherwise would have cost $15-20 million US. So that's a good start. But the other part is that we will setting up a joint development committee working with us so we can tap into their expertise, their connections in the field of HCC, because they know it quite well. So they will be spending time, they will be spending money. We will be retaining the full rights with regards to sort of fostrox, with the ability to move forward on our own, or with the ability to partner as we see fit. So, and they've spent quite some time on the program, so we feel that this sort of very nicely validates the data that we see in the ongoing study, and when we compare with what patients would anticipate to get sort of efficacy in this patient population. The other part, and this is a sort of somewhat of a complicated slide, because the world of oncology and different tumor types is usually a very, very heavy competitive landscape. And that's not the case in second-line liver cancer. So that if you go to upper left, first line, every patient today in first line will get immunotherapy combination. They will eventually progress to second line. In that second line space, there's nothing approved. There's no evidence for use. Guidelines recommend clinical trials. And we then look at sort of what are other companies developing in that second line space. And that's the kind of the cake-like thingy that you see up here. And basically, there's very little ongoing. Where you see sort of circles is where there's programs in development. And in that green sort of section of the cake, there are a number of additional PD-1s, PD-L1s being developed. Using a PD-1 in second line after you've used it in first line is been proven to be not very effective. So we can kind of regard that. So if we look at the rest of the cake, there's very little ongoing. And as a liver-targeted treatment, we are at the forefront with regards to bringing a treatment to market to be the first approved option. So with that, I'll just kind of summarize and go back to where I said, sort of the four kind of steps on the journey. We are doing what no one else is doing. We sort of, I think the panel here talked about differentiation. We are quite different from what everyone else is doing in liver cancer. We have the first and only liver-targeted treatment. And we've shown nicely that we can, for a lack of better phrase, dump it into the liver very effectively, and in the liver it kills tumor cells. It spares healthy liver cells, very important. Data we're seeing, substantially better than what you would expect from current treatments in this space, and there is a first to market, fast to market play here. There's an opportunity to be the first approved treatment options. And if we make it to the market, so that's the other part, sort of from a commercial viewpoint, if we hit this, there is a very low resistance to commercial uptake. So there will be a physicians waiting to use it. So we don't need to change the way they are treating patients. And that market in and of itself is worth in excess of $2.5 billion. So with that, thank you.
Thank you so much, Jens.
I was going to leave that on, sort of in case there were questions I could refer to it. But sort of, if I need it, sort of, then I'll ask it for backup.
Absolutely. Come join me here in the center. It looks so great in the camera when we stand together. What is the reason for a higher number of liver cancer in Asia?
A lot of it is driven by hepatitis B and hepatitis C, and sort of vaccinations haven't gotten as far in that part of the world, etc. So basically, hepatitis. But I think, and what we're seeing, just to kind of expand on that, and that backs to the obesity question. So what we're seeing at the moment, because then I do get the question, oh, is that going to go away, and therefore this is going to become a Western disease because of obesity? And the answer is no. Yes, HCC due to hepatitis is going down, but that's being, again, for a back of sort of, it's not a good wording, but it's being compensated by sort of the obesity element. And yes, that is growing faster in the West, but it's not far behind when you look at China, etc., with regards to fatty liver disease.
Just then, a follow-up question that I got in my mind is, so if that is a thing, how have you sort of planned for the Asian market when you make the plans for your company?
Well, that's why it was so important. So we did the proof of concept monotherapy in Europe, but sort of as we moved into, and it was always, since we are liver targeted, we're combining with the systemic therapy just to ensure that we cover the metastases as well. But when we moved into the combination study, that's why it was so important to include an Asian market, sort of, or a country, hence Korea. I was included to ensure that, one, we can show that it works in that etiology, because the patients are a bit different, and also from a partnering perspective, etc., to ensure that sort of that part of the world is covered in terms of sort of having shown efficacy. And thirdly, since there are more patients in that part of the world, they recruit faster, which is also a benefit.
Good. You talked a lot about the competition already, I think, and the fantastic cake diagram. But we still have a question about, is it anything else that comes to mind that makes you stick out of the competition?
I think the reason we stick out is because we focus on second line. Everyone, I mean, the holy grail usually sort of in treatment is you want to be as early in the treatment algorithm as possible, i.e. everyone wants to be in first line. And we see a massive number of studies in first line, and there's a massive number of basically the same. There's a PD-1 combined with something, and everyone is trying to fight for the first line. And that's all good, and I don't really care who wins. Because when you move from first to second line, you need to do something different. You need to attack the tumor with a different mechanism. And for reasons a little bit unknown to me, no one else is doing it. So we're kind of the only one targeting that second line. I think historically, there's been relatively few patients in second line that have been treated, because first-line treatments haven't been so good. They've been too sick when they get to second line. We see with the first-line treatments today that more and more patients are fit enough for second line. So that patient sort of number is growing. So perhaps if you look ahead, more will target that population, but they can. But we are first.
I'll take your word for it. And speaking of words and evidence, can you discuss the results in your ongoing phase 1B and 2A study? Yeah,
we still have the study open, which sort of we would have looked to close it sort of a year ago, because that's how we anticipate how long patients would be on treatment. They stay on treatment way longer than we thought. The patient who's been the longest on treatment has been sort of treated now for 27, 28 months. And remember, median time to progression is usually, and they get off treatment at 3-4 months. So they stay way longer on treatment than we've seen before. And I think that's the feedback we've gotten from physicians, is that sort of they want to make sure that the disease stays under control as long as possible. And that's the most encouraging part of what we see, and significantly different from what they get today.
You hope to obtain accelerated approval and not have to conduct a phase 3 study. Can you elaborate? Or so it was said
I will adjust that a little bit.
Yeah.
So that we hope to get accelerated approval. We still need to do a confirmatory phase 3, sort of at some. So you will never get out of that. But sort of you do a phase 2b for accelerated approval, confirm it with the phase 3.
Well, I think our time is perfectly up. Jens Lindberg, thank you so much for your presentation. Jens Lindberg, everyone.
Thank you.